Welcome to the debate. Today, we are looking at the pre-hospital use of chemical restraints, specifically ketamine, and how the medicalization of agitation through terms like, excited delirium, has sparked a highly contested paradigm shift.
Yeah, it really is a massive collision of pre-hospital medicine, law enforcement, and civil legislation. I mean, states are stepping in aggressively to take control away from clinical directors.
Right. We've seen Colorado pass House Bill 211251 to heavily restrict ketamine, and Minnesota essentially outlawed law enforcement training on excited delirium entirely.
Exactly. And on top of that, we are witnessing the unprecedented criminal prosecution of paramedics for their field decisions, which is just permanently altering the landscape of emergency response.
To frame our discussion right up front, I argue that pre-hospital chemical restraint is a vital, evidence-based medical intervention absolutely necessary to protect severely agitated patients from acute, life-threatening physiological harm.
And my position is that using ketamine for poorly defined conditions like excited delirium frequently serves as a dangerous tool for law enforcement compliance rather than medical care, carrying unacceptably high physiological risks that demand strict legislative restriction.
Let's strip away the legalities for a moment and look at the sheer biology of a street-level behavioral emergency.
Okay.
When paramedics arrive at these scenes, they aren't dealing with a static situation. Continuous violent agitation triggers a deadly physiological cascade. Like, we are talking about profound hyperthermia and severe rhabdomyolysis.
Wait, before we dive into the cascade, we have to address the trigger for the intervention itself.
Sure.
You're describing the clinical pathway of excited delirium, right? Which is a term the American Psychiatric Association explicitly states does not exist.
Well,
I mean, it's totally absent from the DSM-5. The APA notes that the symptoms usually attributed to it, things like superhuman strength or being impervious to pain, are not clinical observations.
they're highly subjective, yes.
They are law enforcement justifications for force, and they are disproportionately applied to black men in police custody. You are building a life-saving medical intervention on a diagnostic ghost.
But you're treating the ghost as if it negates the physical body. I will readily concede the term excited delirium is deeply flawed and historically burdened.
Highly burdened.
Right. And the National Association of EMS Physicians now refers to it as severe, acute, undifferentiated agitation. But arguing over the DSM-5 classification while a patient's core temperature hits 105 degrees is like refusing to put out a house fire because you're arguing over whether the spark came from a faulty wire or a match.
Okay, but see this?
The house is still burning.
A house fire requires actual flames, though. You're assuming the fire's always raging just because a police officer says it is.
The fire is the physical thrashing. Like when a patient violently fights against physical restraints, they are literally tearing their own muscle fibers apart. That is rhabdomyolysis.
Right.
Those dying muscle cells then dump their intracellular contents, specifically massive amounts of potassium, into the bloodstream. The heart relies on a highly precise electrical gradient of sodium and potassium to beat.
Which is a delicate balance.
Exactly. When you flood the bloodstream with potassium, it acts like an EMP. It short-circuits that electrical gradient, causing immediate cardiac arrest.
Which assumes the agitation will inevitably cause a lethal potassium spike.
It's not just the potassium. As the muscles break down and the patient hyperventilates against restraints, their blood becomes rapidly acidotic.
The pH drops.
Yes. An acidic environment makes the heart muscle highly irritable and prone to fatal arrhythmias, like ventricular fibrillation. Combining an irritable heart with a potassium EMP is a recipe for sudden death. Refusing to intervene pharmacologically doesn't protect the patient. It just lets the bomb go off.
The EMP analogy implies the bomb is actually armed in every agitated patient, which just isn't true. Look at Minnesota's statute 626.8437.
Right, the training ban.
Yeah, they didn't just ban the term excited delirium. They prohibited training on it because the scientific evidence does not support the physiological assumptions you're making. The legislature recognized that a paramedic arriving on a chaotic scene is getting their clinical picture from police officers who are just trying to cuff someone.
I think that's a mischaracterization of EMS.
But the officer says he has superhuman strength, and suddenly the paramedic assumes a fatal rhabdomyolysis cascade is imminent.
That implies paramedics are incapable of independent assessment. The NAISP Joint Position Statement stresses that the decision to sedate must be a purely independent healthcare decision made by the clinician.
On paper, sure.
It is expressly not to assist law enforcement with custody.
But how independent can that assessment be when the intervention relies on symptoms that are basically indistinguishable from sheer terror?
What do you mean?
If someone is fighting because they are terrified of an aggressive police encounter, their heart rate is up, they are sweating, they are fighting back, they are biologically reacting to a threat. Administering a powerful dissociative anesthetic to a physiologically healthy but terrified person introduces catastrophic, totally unnecessary risk.
Let's define exactly what that intervention is doing. Because ketamine is uniquely suited for this crisis. It is a dissociative anesthetic.
A very powerful one.
Right. It doesn't just put a patient to sleep like a traditional sedative, which can dangerously depress the central nervous system. Ketamine blocks NMDA receptors in the brain, essentially cutting the phone lines between the conscious brain and the body's sensory inputs.
Okay.
The brain still functions, but it's completely disconnected from the environment.
Which is terrifying for a patient who is already in a state of panic.
But it instantly stops the thrashing. In the context of the paramedic evidence-based medicine CAT worksheet, ketamine achieves adequate sedation in 85% of agitated patients.
I've seen the worksheet.
Most crucially, it works in a median time of 5 minutes. Compare that to haloperidol, a standard antipsychotic, which takes 17 minutes. Haloperidol tries to alter the brain's chemistry while the body keeps fighting.
Sure.
Ketamine disconnects the body entirely. When muscle tissue is actively breaking down and acidifying the blood, a 12-minute difference is the literal difference between recovery and cardiac arrest.
5 minutes to sedation is fast, I'll give you that. But we need to examine what else happens in those 5 minutes.
Okay.
The Sullivan meta-analysis driving that exact CAT worksheet reveals a horrifying statistic. There is an endotracheal intubation rate of 20% for patients receiving pre-hospital ketamine.
Well,
1 in 5 patients required a plastic tube shoved down their windpipe just to breathe.
Intubation is an advanced airway maneuver, yes, but it is a standard manageable procedure that paramedics perform regularly.
Manageable?
You weigh a 20% risk of needing airway support against the near 100% mortality rate of acute hyperkalemic cardiac arrest in the field.
You cannot dismiss a 1 in 5 intubation rate as a manageable procedure when it occurs on a concrete sidewalk instead of a controlled trauma bay.
They are highly trained for it.
The Cole study showed adverse side effects in 49% of ketamine patients compared to just 5% for haloperidol. We aren't just talking about mild oxygen desaturation here.
I know the Cole study.
We are talking about hypersalivation, where the patient essentially drowns in their own secretions. We are talking about laryngospasm.
Laryngospasm is a known side effect of ketamine, but it is usually transient. Paramedics are trained to push past it with positive pressure ventilation.
Transient or not, it means the vocal cords literally snap shut. They clamp down and completely block the airway.
Which can be ventilated through.
But the lungs try to pull in oxygen against a closed pipe, dropping blood oxygen levels to fatal ranges in seconds. The NIH Executive Summary on Prehospital Ketamine explicitly found that higher doses, anything over 2 milligrams per kilogram intravenously or 5 milligrams intramuscularly, massively increase these severe adverse events.
Which is why dosing protocols exist.
Yet paramedics are frequently giving the high-end 5 milligram intramuscular dose precisely because they need that rapid 5-minute takedown you mentioned. You are trading a hypothetical cardiac arrest for a guaranteed respiratory crisis.
It isn't a guaranteed respiratory crisis. It's a known risk profile managed by trained clinicians.
A very high-risk profile.
When you give haloperidol and wait 17 minutes, the patient is still thrashing, still generating lactic acid, still dumping potassium. The fact that ketamine works rapidly via intramuscular injection, meaning a paramedic doesn't have to find a vein with an IV needle on a violently struggling patient, makes it the only viable option to short-circuit the physical trauma safely.
Viable if the dosing is accurate. But dosing ketamine requires knowing the patient's weight.
Right.
Have you ever tried to accurately guess the weight of someone violently thrashing in the dark while 4 officers are physically pinning them to the ground?
It's an occupational challenge, yes.
The NIH report highlights profound dosage inaccuracies in the field, which directly correlate to those 20% intubation rates. Overdosing ketamine in these chaotic environments is remarkably easy, and the immediate consequence is respiratory arrest.
Which is why medical directors implement rigorous quality assurance reviews for every single chemical restraint protocol.
Internal quality assurance reviews clearly haven't been enough, which is precisely why legislatures are stripping this discretion away from medical directors.
And I'd argue that's an overreach.
When clinical protocols fail to protect the public from massive overdoses, the law has to intervene. Colorado's House Bill 21-1251 didn't emerge from a vacuum. It emerged because clinical oversight failed spectacularly. The law now mandates strict, non-negotiable boundaries.
Boundaries that are entirely impractical in a street fight.
Boundaries that save lives. The law requires EMS providers to actually weigh the patient or use 2 trained personnel to agree on an estimate before pushing the drug.
Yes.
They must have advanced airway equipment completely prepped and physically available to manage the exact laryngospasm we just detailed. And crucially, it explicitly prohibits peace officers from directing, compelling, or unduly influencing EMS to administer ketamine to sedate someone for suspected criminal conduct.
Which I agree with.
It legally forces the paramedic to be a clinician, not a chemical enforcer for the police.
But forcing a paramedic to act independently of law enforcement is fundamentally correct. The NAEMSP guidelines already mandate that ketamine should never be used for law enforcement purposes.
Right.
But Colorado's legislation, and specifically the criminalization of paramedics, introduces a devastating chilling effect on emergency medicine. Let's look at the Elijah McLean case.
Okay.
Paramedic Peter Sachunyek was convicted of criminally negligent homicide and second-degree assault. He received a 5-year state prison sentence.
He administered a massive, fatal overdose of a powerful sedative without conducting a basic baseline medical assessment?
Well, a 5-year sentence, the absolute statutory minimum for second-degree assault in Colorado, reflects the severity of using a lethal drug recklessly. But consider the systemic reality of that sentence. Sachunyek was operating in a highly volatile, completely uncontrolled environment.
That doesn't excuse abandoning basic protocols.
Firefighters, EMS unions, and medical directors are warning that prosecuting paramedics for outcomes in chaotic scenes is going to decimate the profession. You are turning first responders into scapegoats for interagency failures.
Scapegoats?
If a paramedic believes a miscalculated weight estimate in a dark alleyway will result in half a decade in state prison, they are going to hesitate.
Hesitation might have saved Elijah McLean's life. He wasn't experiencing a lethal physiological cascade until he was forcibly restrained, choked, and injected. At the trial, the prosecution made it clear. He was treated as a problem to be erased with a syringe, not a patient requiring care.
That was a tragedy, without question.
Shanine McLean, his mother, testified that the paramedics could have intervened just by saying, "Stop hurting my patient." Instead, they deferred to police momentum.
By legally weaponizing that hesitation, you ensure that the next patient who actually is in the throes of lethal hyperkalemia doesn't get the drug they need to survive.
I don't think it's weaponizing hesitation.
A paramedic terrified of a homicide charge will step back. They will withhold rapid sedation. We will end up with first responders watching patients die of physiological collapse because doing nothing carries less legal risk than attempting a high-stakes, life-saving intervention.
Accountability is not a weapon. Paramedics operate with the power of life and death. If they carry a drug that fundamentally stops a human being from breathing, they must be held to a standard that matches that lethality.
But the environment...
We cannot accept a lowered standard of medical care just because the environment is difficult.
Well, we are left staring at an impossible tightrope in pre-hospital medicine. On one hand, stripping paramedics of rapid pharmacological tools, either through blunt legislation like we see in Colorado, or the looming threat of criminal prosecution, removes a critical intervention needed to stop a fatal physiological crash.
Right, but
Taking away a medication that can halt severe rhabdomyolysis and acidosis in 5 minutes leaves severely agitated patients in acute, life-threatening danger.
On the other hand, the alarming 20% intubation rates and the historical weaponization of diagnostic ghosts like excited delirium mean we simply cannot leave this unchecked in the field.
Yeah, I hear you.
The intersection of high-risk dissociative anesthetics and the coercive presence of police has proven fatal too many times. Strict legislative safeguards, mandatory airway prep, and absolute criminal accountability aren't an attack on paramedics. They are a necessary defense of public safety.
It demands an incredible balance. Emergency medicine requires decisive, aggressive speed to save lives, while simultaneously demanding the absolute fundamental duty could do no harm. It's a tension resolved in split seconds on every single call.
Absolutely.
For those listening, exploring the clinical data from the NAEMSP alongside the legislative texts from Colorado and Minnesota will really illuminate the profound stakes we've discussed today.
And you're operating in the chaos of the street, the diagnostic landscape is incredibly murky, and the consequences of getting the biology or the law wrong are permanent.
Figuring out how to navigate that hurricane without letting the storm wash away clinical judgment is the defining challenge of modern EMS. Thank you for joining us.